Hello, everybody. Thank you for coming to the National Grand Rounds Senior Faculty Research Highlights. Take a seat, yeah. And please, presenter, can sit at the table. Thank you. So to respect everybody's time, we'll get started. This is our National Grand Rounds with Senior Faculty Research Highlights. Paul and I are the moderators, and these are our disclosures. I want to introduce both presenters first, and then they'll present one after another, and then following, we'll have actually open for questions and discussion comments. So we have, privilege and honor to have Dr. Gail D'Onofrio, who is the Albert E. Kent Professor of Emergency Medicine, Professor of Medicine at Yale School of Medicine, Professor of Epidemiology at Yale School of Medicine, Public Health, and also a member of the National Academy of Medicine as well. She also has very internationally well known, as we all know, PIs, in terms of NIH funding over 20 years, clinical trial work, training program, really a commitment to training the next generation of investigators in emergency and addiction medicine. Apologize. Next, we have Dr. Adeoye, who is a Barnes-Jewish Children Healthcare Distinguished Professor of Emergency Medicine, Chair of Department of Emergency Medicine, Washington University School of Medicine, and member of the National Academy of Medicine as well. He also is a PI of a clinical trial network in stroke, editor board in Stroke Journal, as well as HH Stroke section. He is also an entrepreneur of actually one of his first grants that he did and become a company now, and he's a chief medical officer for that as well. Welcome, let's welcome both. Going to close. Let's see here. Okay, now try to close here. Seem to close now. I'm going to get out of here. Oh, there it is. Okay. Is this one? Yes, Gail's. All right. So first presenter is Dr. D'Onofrio, professor. These are your slides. Would you like to use this mic or this mic?
Sure. I'll use this. That's fine. That's great. Okay, good afternoon. So we were just said we could talk about anything really in highlighting our career. So I'm going to talk about some new innovations and discovery, particularly around addiction treatment. And I'll kind of weave that back into some other things that I'm doing here. And if you have any questions, feel free. I have no disclosures, but I am funded by quite a bit by NIDA and a lot of other agencies, and I will talk about some extended release buprenorphine that was provided to NIDA through Braeburn, and I have no contact with that company. So imagine a disease that causes a death every 5 minutes, that has an annual cost of over $1 trillion, that we have very effective treatments for, yet very few people get it. And we, as emergency physicians, can offer 24/7, 365 care, as we know, to many of our patients with drug-related visits or not. And that's because that's where most of the patients are. And hearing the group before us, it's not urgent care, we just are the healthcare system. So Let's just get used to that. So we really know the consequences of this disease, and I've been constantly always indebted to a gentleman, Mark LaRochelle from Boston University, who looked at actually in Massachusetts a few years ago, over 17,000 visits for non-fatal opioid overdoses in all of Massachusetts, and found that if you looked a year later, that only 3 out of 10 ever received any medications for opioid use disorder after that visit, and that the mortality rate was quite high, reached 4.7 deaths per 100 person years. Nothing really exceeds this or gets close than ST elevation MI. Also noted that if the person had been started on an opiate agonist like buprenorphine or methadone, that mortality was significantly reduced. So why don't we adopt things that we know are evidence-based? It's a great question. I wish I had the answer. But there are things in this case that we can look at. There's lots of things that are barriers to clinicians as well as patients. For some reason, emergency physicians and providers are reticent to prescribe. They often say they lack somewhere to send them, which most of the time I could find for you. There's risk of precipitated withdrawal. And then, of course, for the patient, there are a lot of logistical reasons. We heard that even this morning if you went to the plenary, really, which was not being able to get pharmacies, and these individuals can never find their medicines at the pharmacy. They have insurance problem, transportation. 50% of them are not in enough withdrawal at the time that you see them, so that they may not be able to be started right then, and you may not be someone who gives out induction on your own, and the patient may have some treatment ambivalence. So imagine a solution that could overcome all of those. Not everything, because there's a huge barrier. It's called stigma. It's everywhere. But at least those that I talked about, what if we could just get rid of all of those? So we can. So I'm going to show you this really breakthrough. I'll talk more about this afternoon. In another forum, but there is now a 7-day injectable buprenorphine formulation, and we studied it under an IND formulation as CAM 2038. It's now known as Brixadi. So what you need to know about this is these are actually plasma concentrations of medications. So the first one here, can you see that? No, it doesn't show. But the first one is sublingual and has a really rapid rise. You'll see like reaches almost 6 nanograms per milliliter very rapidly and then deprecates. And that's why if you get into trouble with it, you get into trouble pretty early, or it also can help people pretty quickly in about 30 minutes because it really reaches its plasma level quite fast. As opposed to the new Brixadi, which has a gradual upslope and really at 4 hours reaches maybe around 1.6 nanograms per milliliter, and then goes and steadily upwards and stays pretty constant for 7 days. So it's a great thing because it has a gradual rise, and it stays for 7 days, and it works very well. So we studied this. We used the 24 milligram, which is equivalent to 16 milligrams a day. It comes in a really tiny syringe. It's only a volume of 1 milliliter, and it's less than an inch, like 3/4 of an inch. It really doesn't hurt at all. You can give it almost everywhere. They suggest not to use the arm initially because there's some variable absorption, but can give it in the stomach, the thigh, and the gluteal area. As part of a very large trial that we're doing called Innovation, where we are randomizing people to sublingual versus the injection, and we are looking at their engagement in treatment at 7 days. That is ongoing. It's almost coming to an end. There's almost 2,000 patients in that trial. There's now like 1,920 in that trial, and we have 31 EDs around the country who are participating in that trial. But as part of that trial, we did an ancillary focus because we wanted to see if it was feasible to give this medication at lower levels of withdrawal. So we were looking at withdrawal signs that are really less than 8, COW scores that are less than 8, and hypothesized that fewer than 20% of patients would exceed a 5 or more increase in COWs, and less than 10% would transition to precipitated withdrawal within 4 hours, and less than 10% would also within 1 hour. And this is a quick overview of it because I'm not going to talk a ton about this study, but it was great in that we had 100 patients. 63 of those were between 4 and 7, and 37 were between 0 to 3. We had 10 patients who went 5 or greater in their CALs, and then we looked at who transitioned and what we consider precipitated withdrawal. All the cases of precipitated withdrawal were adjudicated by our experts, who are Dr. Loftwell and Dr. Walsh from Kentucky, who did the phase 2 and 3 trials on Brixadi. So, and what we found was that there were actually 2 people in the 4 to 7 range who had an episode of precipitated withdrawal, and 5 in the 0 to 3 range, so that was pretty high. So we had included the 4 to 7 in our major trial, that then we could start the injection at as low as 4. And that's what we would pretty much recommend. And so that really does a lot for you, because you can give it for people early in withdrawal while they're in the ED. You can give it for people that are very withdrawing. And you have 7 days to get them to treatment. We presented a paper on this. It's in Academic Emergency Medicine if you want to read more about it. But one of our investigators, who runs also a bridge clinic, had transitioned 50 patients to the 1-month Sublocade after this. So it's done very well. In the main trial, we've had very little emphasis of precipitated withdrawal, and for some reason everybody worries about this constantly, but we haven't had that. We haven't seen that. This was our very first research letter at 1,200 patients. At 1,200 patients, again, half with XR and half with sublingual, we had only 9 cases, less than 1% of precipitated withdrawal. So this is a little updated version of that. Now again, we have much more than that. So as of this, it was 1,900 patients, and we only have, at this time, 14 cases of precipitated withdrawal. And 5 of those are in the XR group. And you can see, if you look at the chart, that the black circles are all the different locations of our enrollments, and then the stars are where they occurred, and the red are from sublingual, and the blue are from XR, and they're kind of all over the place, so there's no commonality to this. We can't think of any commonality. So again, less than 1%. So again, we have we just can run through all those barriers if you can get it. It's about $450. Many of us have gotten it through our P&T committees. But also imagine that we had innovative induction strategies. And Dr. Herring was the lead on this, and that's because several of us have been using high dose off and on, and we really wanted to get this published, because if we're just doing it, we can't just do it. And so at Highland, he'd been doing quite a bit of this. So we looked retrospectively back at 12 months of patients that he had seen. They were over 579 encounters, 391 unique individuals. There were no cases of respiratory depression, and there were only 5 cases of precipitated withdrawal, and it was not dose dependent. So we know we can do it in a retrospective style. This is probably the best thing that came out of it, and that second line is the precipitated withdrawal. One was in the lower one, and one was in the higher range. The length of stay was really only different in that if you got a small amount, you stayed there longer than if you got a high dose. And that's probably because if you had a smaller dose, it was a reason. There was probably a person was older, had COPD. There was some worry that the individual had, because most of these people are seen by their advanced practice practitioners. So anyway, no respiratory depression at all happened, and so we know that we can give it at higher doses retrospectively. This is a great schematic here from Dr. Greenwald and Michigan and his folks, and it's really exciting to see about this is, again, you have that same plasma. I don't have let's see if I have it. Does that work? Oh yeah, here we go. You have that same plasma levels here and over time over here. And this was 5 different individuals who were known heroin-dependent individuals who were volunteers to get a certain amount of buprenorphine. And so they were given up to 32 milligrams or as low as 0 milligrams. And what you can see here over time is the concentrations from the different dosing. And that red line here is where you have a liking, which we know as kind of drug liking, that you're craving to use some other things not prescribed for you. So if you can stay above this, then you're pretty good. So if we can stay up here really in the 24, 32 range, we know we can do pretty well over that day versus if you end up giving a very small dose, 2, 4, 8, during part of that day, you're going to find that you really are craving, and that's why a lot of people will go out and use. So now we're in the midst of going to just start a high dose versus a low dose induction strategy. Dr. Hawk is here. She is the PI. Dr. Herring and I am helping them. And so pretty soon we will know it's a dummy blind trial, so people will receive 1 active drug and 2 placebo or 3 active drugs. They look exactly the same. We're not going to know what they are. No one who gives them is going to know what they are, and we'll see what happens. We'll start enrolling in August. So also imagine that we could do it in a different way than even in the ED, and that's that we can do it by EMS. And now there are some great people who are working on this, both at Cooper, Dr. Carol at Cooper and Dr. Jean Hearn out in California Bridge with Dr. Herring are both administering quite a bit of buprenorphine in the pre-hospital setting. In Cooper, they're doing it with only overdose patients, and in California, they're doing it with overdose plus patients who are withdrawing. They're giving it in the field. And another group in North Carolina, which I just saw the paper this week, so I couldn't put it here, has also given out quite a few for both withdrawal and overdose. So that is probably coming, and we're probably going to study this hopefully very shortly. So imagine also that we had an EHR that could do some of this screening or kind of figure out who are the patients that we want to look at. And so I wanted to highlight Dr. Andrew Taylor here, who has worked a lot on this. He's an informaticist and has developed some decision trees and logic reasons and could give out real-time alerts. This is very complicated. I never really understand it, but he can put people into different kind of cohorts and which cohorts should be treated. Because what I hear most of the time is people don't want to screen, and I don't blame you. I don't want to screen either. Everybody, the nurses have 5,000 things to do. So in this disease, most of the time you can see them. Most of the time they come and tell you they're withdrawing, they want care, they have an injection abscess or an infection. But in those cases that sometimes you don't, you might be able to see that just from looking at some logic from EHRs. And imagine if we had great clinical pathways, and this is also a shout out to Dr. Melnick, who's also an informaticist at Yale, who really helped me put our whole protocols into some kind of embedded into the EHR. So you would just have to look at it. It basically does everything you want. And we put it in a BUP initiation app, which you can download. It's free on your phone. It will tell you what the clinical opiate withdrawal scales is. It has whether or not patient has opiate use disorder, whether or not the patient's ready to are motivated to use for treatment, et cetera, and we're just updating that now. But excitingly, Epic has adopted this, and now anyone who has Epic, you can turn this on at your site. It is really, really exciting because this tool can help you diagnose, assess level of severities, and patients' readiness to initiate treatment. And then for patients who want to begin treatment, there's a smart set. The smart set comes right out, and you can order whatever you want through the smart set. It'll tell you what to order. It'll give you instructions for discharge on overdose prevention. It'll print out a prescription for naloxone if we're lucky enough from our Department of Public Health to be able to have it, and we hand it out, dispense it to people. Whatever you want it to do, it can do it, and it can set an appointment for you. So that's all great news. Of really predefining all these order sets. It'll even write your note for you. So once you put a few things in, this is what it can tell you. This person has severe disease. They're ready to go. This is what I did. I'm giving them a script for this. They're going to be seen at what? Now comes the note. So it's really like one-stop shopping here. This team also did this wonderful thing about looking at contagion, which I just think is really exciting, that they then took all these people as part of another trial we were doing at 5 healthcare systems, and they were able to look at an interaction and the dose response if one person had seen one other person doing it, and then were they going to do it. And you can see from all of that green is that the more that you see, the more you will do. So really see one, do one, teach one. So I'll end with this last thing, is that there are other new treatments that are over the horizon that you may not even know about. You wouldn't know this. This is a drug that is just under development. It's under its first human trials as we speak. It is called CS1103. It is a broad spectrum antidote for all kinds of drugs that you can be acutely intoxicated with. It rapidly reverses any of these toxic effects: fentanyl, methamphetamines, cocaine, any of these stimulants, xylazine. It detoxifies the body very quickly, and it's on its first human trials. It is a very small molecule drug, as you see here, that binds, and it clears the system very quickly. It can be given in a variety of different forms, IV, IM, PO, and it will really clear within a very short period of time any of these drugs that are in the body. And you can see that that opens it up to a lot of exciting things, like could you then just slip in some buprenorphine or something else that you want at that particular time. So this is great. We also know that many people come in who really didn't know what they were taking, and they could have taken a lot of different things and a lot of overdoses. And so I think that hopefully these human trials will do well and we can see it. So we know treatment is effective. Providing treatment is not a choice, and you all have the ability to save a life. So that's it.
All right, I think it's afternoon. Good afternoon, everyone. Thank you very much for the opportunity. Paul and Peter gave me the option of speaking about whatever I wanted, and I've sort of been a bit of a proselytizer for asking us to pause as emergency physicians and think about what it is that we want to do, and then the goal being to sort of find fulfillment in our careers. And so with that, I thought I'd talk about using mentoring and individual career development plans to facilitate success. My faculty are in the room. I've heard this ad nauseum. I apologize. I'll do it again. And I'll try to not to stray from my slides so we're on time. Here are my disclosures. The last two is, this is a clinical research orientation to career development, but a lot of the lessons are certainly applicable to education, operations, any number of other things that people are interested in. And then, of course, this is my story, and everybody's story is different in whatever fashion. And so what I'm going to tell you is that you need a plan. You need people who have done this before. You need to use them. And you need to not be afraid, right? You should use the resources that are available to you wherever those resources are. Whatever the issue is that you think you're dealing with, somebody has dealt with something similar. Even if it's not identical to your situation, they can certainly help you navigate whatever the challenges may be. What then is career success in emergency medicine? In general, the notion of having completed something. But for academic success, it really depends. What are your goals? What's the environment that you're in? What are you particularly interested in terms of a field of study? And in terms of Sherpas, the people that I have been influenced by, in 2004, Dr. Susan Stern has no recollection of this, I'm sure, but she was the Midwest Regional SAEM speaker in Milwaukee, Wisconsin. And at that session that I went to present my very first abstract at, she said, make sure you have 2 scholarly products a year. It's a very simple thing that just stuck with me and really resonated with me, because if you have 2 scholarly products a year and you fast forward 10 years, in my case, you fast forward 20 years, you have this portfolio and a body of work that says, oh, here's what this person has done. And so it seems readily attainable for all of us to say we're going to have 2 scholarly products a year. So I took that away from that meeting in Milwaukee in 2004. And then Dr. Collins, who doesn't show up anywhere other than this one random abstract that I actually looked for on Google Scholar and can't find. It's not anywhere. It's not published anywhere that I can find. But Sean is a dear friend, colleague, mentor, who doesn't show up anywhere on my byline. But I'll show you in a few minutes. I spent a lot of time just sort of helping, guiding, and providing support as I went through my journey. In terms of luck and opportunity, for anyone who was at the plenary today, Bob Newma mentioned the Neurological Emergency Treatment Trials Network and NET. And so as NET was going in, and Bill Barson and Rod Silbergleitz and others were writing that grant, I was charged with this one table. So Holly Ledyard is an emergency physician neurointensivist at the University of Utah. Holly and I were fellows together. And at that point, there were 25-page grants to the NIH. And we put together this one table. I think it took us like 6 months. It felt like a really long time. As far as we were concerned, we wrote the whole grant because we put together the first demographic table. But that's how difficult it was for us to actually sort of get this done at that point in my life. And in the process of that, working with Bill and working with others, I came up with this one sentence. It took me about a year to write the sentence, going back iteratively. But because it took a year to write the sentence, you know, again, almost 20 years later, the sentence still holds. So I just would suggest that we take the time to think about what it is that we want with our careers. As emergency physicians, we are pleiotropic. We can go in 25 different directions, and we often do. Right? And so that's good and bad, but it's really important to spend the time to think about what it is that we want to do. And then a lot of people along the way, and as Bob mentioned during his talk today, you know, I do stroke, and so I necessarily work with neurologists, I necessarily work with neurosurgeons, and then there's some luminaries of emergency medicine that you see on the screen there, that again, I had the opportunity to work with and leverage and use their wisdom. And then embrace failure. Laura Negreña to the top right is a neurosurgeon in Cincinnati, one of my mentees who's done really great work. She's the first person I saw put this slide up, right? When Peter introduced me, he didn't say this guy has written 10 grants that weren't funded, right? But it's really important that we share those stories and we share those failures, and so that everybody else who's going through that right now and doesn't appreciate it is able to accept that this is just par for the course as we try to get our careers and our grants off the ground. And then Laura, of course, has done well between, like I said, she's the first person that I saw who put together all these grants that she'd written and did not get. And then from this email from a couple of years ago now, following the K that I helped mentor her for, she has her first R01, she has a DOD award that she subsequently obtained. So my perspective is it's often the last key in the bunch that opens the lock, right? And so as we're going through it, it can get really demoralizing when you put the grant in and then it gets you put it in the first time and you get like a score of a 40. You put it in the second time, you get a score of a 50. You're like, what is going on? Am I getting worse at this? That's just par for the course. And at some point, sometimes you just have to go through it a few times. Scott Janis is a program director at the NINDS, and this is his schematic, which is you build, you get your first win, you establish a pipeline, you improve efficiency, you work smarter, right? And then you maintain the pipeline, and again, utilize the network. In this case, it's talking about a stroke network, but I think the notion of utilizing the network of people that we have around us is even more important than the physical structure of the clinical trial network. And so important and not urgent things that we should spend time on, I think, I'm a big proselytizer for the individual development plan. And that's really what this is about at the end of the day. What do you want to do? And how are you positioning yourself to actually sort of follow a path as opposed to sort of drift and vacillate from side to side across any number of things that we could do as emergency physicians. And so I like short-term goals, I like long-term goals. The short-term goals have to follow from the long-term goals. Defining your roles and finding your mentors and defining how often you're going to meet, defining what your duties are as the mentee and what you're then expecting of the mentor, and take responsibility for the specific tasks and be accountable for what it is that you say you're going to do from one meeting to the next. Along those lines, I met with Bill Barson quarterly for at least a decade or so. And when I met with Bill, I would say, between now and the next meeting, Bill, I will do 1, 2, and 3. And then about 10 weeks in from my last meeting with Bill, I would go, shit, right? And start racing to make sure that I do my part of what I said I was going to do. Because rightfully, if you met with me once or twice in a row and I didn't get done what I said I was going to get done, he had every reason to stop meeting with me if that was the case. And so these are my notes from that first meeting, switching to tenure track, do a couple of things, and then we met again every 3 months for about a decade. And then Sean is another person that I was very fortunate to work with. I sent this email, I can't see my dates on the screen. This is an email from 2013. And I emailed him at, I think, 9:57 a.m. And at 10:04 a.m. he responded, sure, absolutely. When can you talk? All right? So that kind of support and that kind of sponsorship, advocacy, dedication, find out who it is that's going to be able to do that for you. Seek them out, beg them, plead them, beg and plead, and don't shy away from it. And so I set up like specific goals for what it is that I wanted to do and how I wanted to go about them. I sought counsel. I reached out to Sean. Again, like he doesn't show up anywhere in any of my grants. He and I haven't written a paper together that I can think of. But I finish the grants and I send it to Sean, and he gives me this kind of feedback, right? And I say writing is different from writing is different from communicating or conveying a key message. It's a little like those who know Sean will appreciate this. But he wrote, "Don't tease me, just tell me. I don't have time for your like build up. I don't have time for your prose." And so that's one of the lessons that I took away from him over the time. And so I put in this sort of short-term, long-term goals for 2021 to 2030 because I don't think this ends. This is sort of what I'm doing now, and I have to again seek out people who have done this, who I can learn from. And the first retreat, and to the top, the picture on the top left was like during COVID in 2021 when I first got to WashU, and Art Pensioli and Deb Dirks were our sort of visiting professors as we had our faculty retreat, and they were sort of helping us navigate what it is that we needed to do. And then on the right, Don Yealy and Angela Mills were physically visiting us in October, I think, of 2023. Again, using the Sherpas and trying to learn from them and trying to make sure that whatever direction we're rowing in, actually like what they're best at is that external validation, because you're trying to do what you can and you're struggling. Is this right? Is this not right? It's hard. But what they offer you is external validation, and you know that, okay, I am struggling here, but this is in fact the right thing to be doing. And so that's what I think the Sherpas are most good for. And then finding somebody who is a sponsor, and I'm not going to go through all this, but Art Pensioli is by far my biggest sponsor ever, right? Art would make opportunities available left and right that I wasn't really qualified to do, but he would go, "Adeoye, go get them." And so that's somebody else that I think I'm very grateful for overall. And then paying it forward. And I have 1, 2, 3, 4 K mentees up there, and some not my direct mentors, but people that I've had the opportunity to, the direct mentees, but people that I've had the opportunity to work with. And so paying it forward and making sure that we're, again, bringing everybody along with this. And if I had a choice of what I would have done sooner, I would have developed that IDP sooner. So I'm a big proponent of the IDP. So if you don't have one in the room, I would just challenge you to say, then what are you doing? what are you doing? If you don't have, this is the path that I'm going and this is how I want to get there, then what is it that you're doing, especially as an academician? So here's what I told you. Decide what you want. You have to come up with it and make a plan towards it, work on it. Don't freak out. If you don't know what an IDP is and you're like, how do I go about doing that? Talk to lots of people who have done that. Expect that you're gonna like flounder here and there and accept it. For those of us who have had the failures, share it and share it openly. Normalize the failure. Normalize the fact that this is a struggle so that the people who are working on it and feel like they're just on their own actually realize that they are not, and that's par for the course. And I will stop there. Thank you very much.
Thank you both. And now we'll open up for questions from the audience or comments. Please just state your name and where.
Hey, my name is Kyle Swen. I'm a toxicologist over at Baylor College of Medicine. This question is for Dr. D'Onofrio. Do you have data on what happened to those patients that did get precipitated withdrawal in terms of length of stay, if they had any significant morbidity or mortality associated with them? Just
Sure.
because a lot of people are scared of it.
Everyone is still scared of it, but they all did well. They all went home. In general, we keep them over, often they're homeless or have unstable housing so that they're kept in the evening, but they all went home in our subset. In the larger subset, most all of them go home. Sometimes people admit them because they don't have observation or they just whatever. I think it's best to keep them in the ED because we have all the medications to help them. They need more bupe. In addition to that, they can have some ancillary medications as well, clonidine and anti-nausea, et cetera. And then we have a really nice protocol that we give them ketamine, like about 3 per kilogram, 0.3 per kilogram, so about 20 milligrams, and give that slowly over 10 or 15 minutes IV, and you can repeat that. But it's best that people are monitored. We also give people a little bit of Ativan, a little bit of lorazepam, so maybe 2 milligrams just to take the chill off. But people do well. I mean, it's a horrible thing because you make people feel worse, but it really, truly is a very tiny portion of patients. And if we don't do it, then they could go out and die. So, but thanks for asking that.
Thank you.
So just some other things about how things proliferate in our careers of, I have done also a lot of work in heart disease and et cetera, and I'm working with Siren, and I see some folks here from Siren back here, but we are, if any of you are in the Siren network, are participating in ICECAP, which is looking at out-of-hospital arrest, okay, that how resuscitated and coming in and looking at different temperature points of temperature regulation, and that a quarter of them have been enrolled who are overdosed. So there's also a lot of resuscitation types of things that need to be done because these are obviously a different phenotype than what you'd expect from an MI or maybe having a clot. So there are just a lot of opportunities.
Thank you. Any others? Questions or comments?
Thanks for the plug for ICECAP. I'm Will Moyer. I'm the national PI of the ICECAP trial. And thanks to those of you who pay taxes in the United States of America for supporting this publicly funded research. My question is for Dr. Adeoye. How do you get people in their sort of individual development plans to focus on something that will be impactful? Like, how do you have those conversations? And Dr. D'Onofrio, you could certainly respond to that as well. But when you're advising faculty or mentees, how do you help steer them towards doing things that are impactful?
Yeah, thanks for that, Will. I'm always a little nervous when Will has the mic, so and he has not let me down. I think that, obviously people, have their own ideas for what it is that they want their career to look like. I think part of the challenge for impact is making sure people aren't reinventing the wheel. And so that's where the external validation, I think, comes in. And what you'll find in terms of impact is if you ask a number of senior and experienced people, and from a career development point of view from the NIH for Ks, right? They actually like K committees, right? They don't want me to go to Paul and go to Gail and go to Will and get like different advice and then picking and choosing what I think based on my vast experience of a year or two post-residency. Right? And so getting that committee of people, experienced people, knowledgeable people together, again, doesn't have to be research. We're using the research framework because that's where I think it's pretty clear that if you're going to bang your head against the wall with something that's not going to be impactful, and Will says it, and Paul says it, and Gail says it, then it's really foolish for me to spend my time on it. And so using the resources around you, I think ultimately is the best way to try and make sure we're doing something impactful and not just spinning our wheels.
Yeah, and I also think that people have come to me a lot of times with different ideas. And first of all, it does have to be fundable, right? So people may have a great idea, but who's going to fund that? I just can't think of anything. So let's think about another area you're passionate about. So this is an example of what some of what I told you. We have two wonderful informaticists in our department, and they didn't have anything to do with substance use research, right? So Dr. Melnick came to me and said, I want to put this grant in, it's perfect for me. It was a UG3 mechanism. I have to do something. I want to do it with IT. I said, great, do it with opiates. You'll be funded. He goes, okay, do it with me. I said, sure. I mean, it's not his passion about opiates, but what his passion was to get clinical decision making into the EHR and to show that it really made a difference. And Dr. Taylor, who's like really brilliant and does many other things in natural language processing and prediction of things and in AI, said, okay, I want to, and got $1 million from the major grant I had to look at phenotypes and test them in different areas and look at different cohorts. He hasn't drank the Kool-Aid about substance use disorder, right? It's just that was a mechanism for him to show what we could do with something like that. So I think in any suspicion, in any area that someone's interested in, you can find something that's fundable that would be in their wheelhouse that they would like.
Thank you. Other questions or comments?
How often are you asking your mentees or people that you talk to refresh their ideas?
Refresh them. Your developments? Well, traditionally we do it every year as a big deal, but if we're really mentoring someone very specifically, we're probably working with them 4 times a year, but it's really the longer term plan, not just the specifics of what they're doing, but that yearly thing of what's going to happen next and what's really going to get you there. I find that people try to do too much, and I'm usually saying that's not a good idea, because you have this year in your K or whatever, and you only have that amount of time to be invested. And so yes, you could do all these other things, but there's only so much time in a day. Every time you do something, and every grant you do takes you away from your family, your friends, your passions, and your other life. So you better like what you're doing, or it'll be a really horrible life.
No, I'm still traumatized by an October, I forget what the year was, submission that had to go back in July, and my kids were young at the time, and so like it was over. I missed all of June, like the very first month of summer, because I was submitting a grant for the July 5 resubmission deadline. So I didn't submit grants in October for a long time because I didn't want to resubmit it over the summer. Yeah.
But there's never a good time.
There's never a good time.
Thank you. Any other questions or comments? Yeah. Of course.
So, I don't know, there may be some younger people in the room, but those sorts of statements sort of imply you have to sacrifice a lot to like be successful in research. What are things that you can do as chair or senior faculty to help make it more accessible to a broader range of people who can both succeed in science but also succeed in having a well-rounded life?
I will channel Gail and then let her speak for herself. I think at the end of the day, it's investments on the part of the departments and on the part of chairs to allow the people that we are competing with, and again, Bob mentioned this earlier in the day, is that we want to sort of be at least, I think, middle of the road for all those percentages that Bob shared for what proportion of faculty are NIH funded or proportion of faculty are doing sort of high caliber research. So we have to invest as a discipline in that. It's really hard, right? Depending on each of our environments for us to invest. And then we're kind of picking a winner, right? Like we're saying this faculty member is worthy of a 3-year investment, a 5-year investment. That faculty member is not. And so it's really hard, but I think if a department commits to invest in a certain amount, realizing that we're gonna miss on occasion, but we're going to sustain the investment because that's what we've committed to, and pass that on to the next person and see how they do. I think that's what we need to do.
Yeah, it's complicated. It's not easy, so I don't think we should ever plan it to be easy. I always have my 5 Ps, if maybe have heard me speaking them before, but the first one is passion. So you have to have this tremendous passion to want to and be curious about something, all right? And it can be drawn from your clinical expertise or whatever it is that why is the question. My first study of seizures and alcohol-related seizures was purely, I was an intern and they told me to give 5 days of Dilantin. I said, that makes no sense. All right, and all these medical people, did a year of medicine, they said, yeah, you just do that, Gail. And we have this great thing, and the nurses down the street at the shelter give it for 5 days. And my same patients would come back. I said, well, that's ridiculous. It makes no sense. So the first study I did was like Dilantin versus nothing. And then lorazepam came out. Lorazepam was a really nice medication because you could give it parenterally in all different ways, which is hard with Valium, sometimes variable absorption. So I said, okay, well, I'm going to try this to see that we don't have recurrent seizures. And sure, it worked, because the reason for that is when you have alcohol-related seizures, you have lots of them, and then you have to get admitted, and all this mess happens. And they don't really want to be admitted. They don't actually even really want to go to detoxification sometimes. Sometimes they do, but you want to make them not hurt. So I just did that because it was like, why are you doing this? This just makes no sense. So the passion has to be there, but then one has to really be very persistent and be able to deal with a lot of difficulties and not give up. So that kind of perseverance and persistency has to always be there. And then there's people, or peeps, you have to work with a lot of people. You can't do it yourself. And the last thing is you have to tolerate a lot of pain. And I really can't take that away because, we're like rats in an experiment, right? You get funded sometimes and not others. And so it's intermittent reinforcement. And Jeremy, it's true that you could do it without it. And I did that whole thing, that New England Journal thing with help from Andrew Ulrich. We did the whole thing ourselves. I even went to the pharmacy and mixed the medicine. There's pharmacists here, they let me do that back there. I went down in the pharmacy and mixed the medicine and put tape around them, all right, because no one else would do it. But it doesn't mean that it's the right thing to do. So it is a lot of pain, and you can tell very quickly whether a faculty member wants to do that. Because on their own, they start to write about stuff, they start to be curious about something and want to, it's very, I think, absolutely almost I don't think it's ever happened that I've picked somebody that I thought that never did it. I could tell right off if someone's not going to do it. So I think you say you back them, but really they're working really hard. And it's important that that faculty member be paid the same as any other faculty. I don't mean straight clinical, because straight clinical people make a certain amount, that's the way it is. But other academic people who are educators, who are whatever else, administrators, whatever else that they do in your department, they need to be paid commensurate with that. And then they need to get some incentive for things that they do, because they're going to work 24 hours a day. The only thing is you can kind of do it on your, you sort of can do it. I could tell you all these crazy things that I would do. I would go and take really long baths because I said I really needed it, because I wasn't supposed to be working, but really I was just in there writing or working on doing something, right? I would say, I just need a break. When my kids were little, come on, mom's just gonna go in here. No, I wasn't, I was really working. So you just find things that you can do, but if you like it, you like it. But the chair has to support that person with paying them and releasing them from some other things that might be general. Like, people have dashboards of everything that you do. Like, make sure your charts are done, make sure you show up to this, make sure that you teach so many classes, that well, there are some things that you shouldn't have to do, because that's your education section. That's what they do, right? That's their job. And it's not that we don't do it. We do a lot of education in the field because we know what the literature is for a variety of different things. But we may not be doing basic educational stuff because that's what they do. So the researchers sort of have to fight for what is their dashboard. And if we don't do that, we won't have any researchers. We just won't have.
Thank you for that personal share. Yeah. Any other questions or comments? Otherwise, Paul, you have any last words?
No, just thank you so much for sharing your experiences, sharing the cutting edge of where substance use is going, and how to mentor faculty and bring people up by use of ideas.
Thank you, everybody.